Welcome back to Ask Dr. Mingle. I'm Dr. Mingle, family physician, founder and CEO of Mingle Health, and I'm here to answer your questions about value-based care and value-based payment. Let's dig in. Today's topic is the Medicare final rule for the physician fee schedule, in which Medicare packages every year its rulemaking cycle on the quality payments program, the Medicare Shared Savings Program, and related topics. We'll be digging into that today. I finished my review of the details of the rule and have organized my thoughts, my presentation to you into these 4 units. This one is an orientation to and summary of the final rules. I'll hit the high points and watch for my other 3 presentations hitting the details of these major blocks of the rule. Every federal program goes through a similar rulemaking cycle. For Medicare and the physician fee schedule and related rules, this one that I'm talking about, the proposed rule is released every July. Comments are due by September. The final rule is released on or about November the 1st, and this has been no exception. The rules are slated in general to go into effect January 1st of the following year, although some of the rules are retroactive and affect the current year that we're in. In case you want to dig in yourself and get to more details, I've included the references that I depend upon and I find useful. They're listed here. I'll hit the high points of each in the following few slides. Let's move that way. First, the Federal Register. This is where the proposed and final rules are published. If you go here, you can find the proposed or final rule in its entirety. Pictured here is the face page of this final rule. There's a button labeled PDF where you can download a PDF of the entire proposed or final rule. Now, the rules, the proposed and the final rule, were relatively verbose. They contain a lot of explanation. They go through public comments and how Medicare responds to that. It's more efficient when it's finally moved to the Code of Federal Regulations. The individual regulations, just the essentials, are listed in the set of regulations. Everything in the federal government is here. Title 42 contains everything about public health, and Chapter 4 is all about the Centers for Medicare and Medicaid Services, and so on. You can find everything in here. It's not immediately published here after the rules come out. It takes a little time. As of this recording, they haven't yet been moved into the ECFR. Medicare typically creates several summaries. These are the summaries of this final rule that I find particularly helpful. First is this quality payment program fact sheet and comparison table, in which it carefully reviews what the previous rule was and what the final rule says. Find it at the link in the header of this slide or in the previous review of the references. This 2026 MIPS Value Pathways Guide is a 71-page slide deck turned into PDF format. The link, either here in the header or in the prior slide, will take you right to a download of that PDF. It's very useful. This MSSP fact sheet is all the high-level changes of the Medicare Shared Savings Plan program. And it's organized in this press release format, 13 pages. And again, the link in the title of this slide or in the previous slide takes you right to the download of that. With every final rule, Medicare reviews some of the high points of the program. This was no exception. So I've started with this first slide of those interesting high points. 2024 was the most recent completed year of the program before this final rule was released. It was the 8th year of the quality payment program. That includes MIPS and alternative payment models. The merit-based incentive payment system, the flagship of that program, 94% of eligible clinicians participated, which is 489,000 providers out of 520,000. Of those providers, 87% of them were queued for a positive payment adjustment in payment year 2026 based on that 2024 performance. Now, in that year, the highest earned positive adjustment was 1.05% out of the predicted plus or minus 9% available. Now, the few losers, about 13%, were queued for a negative adjustment. Um, there are real losses of 9% of the Medicare book of business. My guess is that 13% includes people with very little to lose, that it just isn't worth responding to the program. And those numbers, the small percentage, 13%, and the fact that they're probably low Medicare participation rates, mean that there's very little money to distribute to the winners. Understanding that the MIPS program is revenue neutral. They only distribute as positive adjustments the money they collect from the negative adjustments. So that remains tiny. Now, in advanced payment models, that's models with a loss and a gain. So it's two-sided. 528,000 clinicians achieved QP status, and it's easy to see now we've turned the corner that there are more advanced APM participants than there are MIPS eligible participants in that quality payment program. Most people who participate become qualified participants or QP. Only 2,000 clinicians hit only the partial QP status. Now, the Medicare Shared Savings Plan has been around since about 2013. There are now 477 ACOs, representing 650,000 providers and organizations, and touching 11.2% of Medicare beneficiaries. I've given you about a one-slide summary of the high-level changes of each of the component programs this year. First, for MIPS, in bold here on this slide are the things that are new. They're 2025, but I think it's important to also remind you of where we stand from previous years. The performance threshold, new for 2026, has not changed. In fact, they set in rules that will stay 75 through the 2028 performance year. Data completeness threshold was previously set at 75% and continues in the rules through the 2028 performance year. Performance category weights have remained unchanged for the last couple of years. They continue. I expect this to go on indefinitely at these levels. Policies and procedures for the various reasons those performance categories need to be reweighted are essentially the same as they've been. There's a new rule regarding topped-out measures. You'll notice over the years that every year we see some fiddling with the topped-out measures. This year, Medicare has targeted the topped-out measures that are particularly important to specialists who don't have a lot of measures to choose from. 19 of them they've restored from that 7-point cap for each of them. They've restored them to use the full 10-point spread of scores, but they've compressed it. So in the upper echelons, in the 80s and 90% performance rates, dividing sometimes at a single percentage performance rate, they've squeezed that entire weighted list of potential scores. So you can now earn with a 100% performance rate a score of 10, and down in the 80s percentage, you'll earn 0 or 1 point. There's 19 measures that have warranted in this year's rule that treatment. Now, you may remember that in the 2025 final rule, they created a new cost scoring system that was based on standard deviations and lined up the mean score with the mean of the overall MIPS performance scale, which, as you recall, is at 75%. You see there at the second bullet in this slide. So a mean score essentially gives you that a score around 7. And then they vary, instead of with the spread of percentile points, they're going by standard deviations, multiples of the standard deviations up and down to spread it. What this has done is created a system that on the average, the cost score doesn't pull your total score down. So if you perform the same in cost as you do in quality, it'll essentially keep that score stable, and bring all scores up a little bit overall. Although in the upper ranges, you may find your score a little lower in this new system than the old. Well, this year they've also brought that treatment into play for the administrative claims measures. So both go into place in this 2026 upcoming performance year. They've also decided to make new cost measures information only for their first 2 years. So you'll learn what your cost performance was, but it won't count into your final score. Now, a couple changes to CAPS for MIPS. That's the satisfaction survey that is elective for most MIPS users, required for Medicare Shared Savings Programs and some other alternative payment models. They're now requiring a Spanish language option for Spanish speakers. They're requiring a web option, and requiring that the procedure be distribute the web survey for those who don't respond, distribute mail for those who don't respond, distribute phone, which really brings it in line with how most surveys are operated these days. MIPS value pathways. We're still on a path to eventually sunset the MIPS, the traditional MIPS system, and go full-time MVPs. They still acknowledge that that's a plan, but have not yet set a date. They are confirming that 2026 is the first year that there's mandatory subgroups starting. Now they've made some clarifications, since there's a lot of confusion how mandatory subgroups is going to work. You don't have to participate within an MVP in these years, but if you do, and you're a large multi-specialty group, you have to break into subgroups that are pertinent to the measures in order to do the MVPs. Now, Medicare's also been a bit confused about how to deal with specialty. That's not an easy thing to determine always for each clinician. So for the MVPs, they're creating a higher dependency on self-attestation. When you sign up for an MVP, and you have to in the April 1st through the December 1st timeframe every year for the following performance year, you will attest to whether you're a single or multi-specialty group and what your specialty makeup is. Medicare's not going to check that in the specs, in the claims. Now, multi-specialty groups of 15 or fewer providers don't have to break into subgroups. Any single specialty group, solo practice, they don't have to break into subgroups either. Only those large, over 15 provider multi-specialty groups have to break into subgroups if you do MVPs. And these are the new MVPs introduced for the 2026 performance year. That's diagnostic radiology, interventional radiology, neuropsychology, pathology, podiatry, and vascular surgery. For the APM, very little changes in that, although they've made some adjustments to QP and partial QP status calculations. Now, there's a threshold both at the QP level and the partial QP level to gain those statuses. Those the weights, those benchmarks, thresholds have not changed since 2021, and they're projected to go through 2026. When there is a hike in after 2026, there will be a hike written into the rules at this point. In both of those in those calculations. Now, as you recall, there's both a patient count threshold by a percentage of patients. You can earn either partial or full QP status, and there's a percentage of charges. And if you get either of those, you're considered a QP or partial QP, depending on which of those you hit. This year, they're subdividing percentage of charges into E&M codes versus all allowed charges. They've also added for everyone, instead of just a calculation at the entity level, they'll calculate at entity and individual level. And every individual will get the score of those 6 options. That's the 2 different percentage of charges, the count of patients at the individual or the entity level. The most favorable listing will be given to each individual participant. They've also removed the medical home model practice size restrictions. That was the parent's practice. The parent organization couldn't have more than 50 providers. That now is gone from those rules. In the MSSP, they've reduced the time that can be spent in a one-sided model to a maximum of 5 years. You must enter a second agreement period in either level E of the basic track or the enhanced track, starting with new contracts after the 2026 year. They're discontinuing the health equity bonus effective for the 2025 year. They're removing Measure 487 from the APP Plus measure set. That's the screening for social drivers of health. And they've adjusted the definition for beneficiaries eligible for Medicare CQMs in a good way. Now they're focusing only on Medicare beneficiaries seen in the ACO that have at least one primary care visit in the ACO. It can't be driven just by a specialty visit. And they've created some continuity through change of ownership. So if a change of ownership doesn't change the makeup of the group, but it changes the tax ID number, you can expect, if you apply for it, to notify Medicare properly within 30 days. You can maintain some continuity in the participation through that change in tax ID numbers. And they relaxed a little bit the 5,000 beneficiary requirements, allowing people with fewer than 5,000 beneficiaries in the first 2 benchmark years to participate as long as they are on track to increase to and above that 5,000 mark. And they made some adjustments to maximum gain and loss that you can sign up for if you're in that category. Now, the big news in this final rule is the introduction of a new model called the ambulatory specialty model. Watch this new model. It has the potential of dramatically changing how Medicare approaches MIPS and MVPs in the future. And now, this program is a 5-year trial through the Centers for Medicare and Medicaid Innovation. Unlike all other programs I'm aware of in the CMMI, this is not considered an alternative payment model. It's a variation on MIPS. It doesn't qualify providers for QP or partial QP status. There will be 2 cohorts, one for specialists taking care of patients with low back pain, and one for specialists taking care of heart failure. Um, and general cardiology is the only specialty that will be considered in the heart failure measure. These other listed specialties, anesthesiology, pain management, neurosurgery, orthopedic surgery, and physiatry are all considered eligible to be in the low back pain cohort. There's 100,000 specialists, they estimate, nationwide that are potentially eligible for these measures. And another essential change, big change in this measure in this program, is that specialists who are randomized, the 40% of specialists randomized into the study groups have to participate. It's mandatory. First ever. The other big change over MIPS and MVPs, you don't get choice of measures. There's a prescribed 4 submittable quality measures, 1 administrative claims measure, 1 cost measure. Now, these are all based on other MVPs, but again, they're looking for a very reproducible measure set, which directly compares specialist performance in cost and quality. With this new program, it's important to understand this timeline. The program was launched by being included in this final rule, November 2025. They expect to publish a preliminary list of providers in December of 2025. They intend to finalize that list for the first performance year in July of 2026. And that first performance year starts January 1st of 2027. Now, every year you expect to see a new participant list come out in middle of the year. You'll have, just like MIPS, you'll have measure submissions due by March 31st following the performance year, and adjustments earned will hit the Medicare payments 2 years after the performance year. Again, 5-year program. The last performance year will be 2031. The last measure submissions will be 2032 by March 31st, and the final payment year will be 2033. We may see the next version of this announced sometime before the end of that program, or again, if this is successful, if Medicare considers this successful, we may see elements learned in this program starting to spill over into traditional MIPS and or most likely the MVP program. So that's, I think, all my content for this presentation. Watch for the details of these programs in those other presentations. And as always, don't hesitate to ask your questions. The links to share those questions with us are here on this page. Correct my answers, contribute your experience and comments. We're smarter together. I'm looking forward to hearing from you. So see you shortly with the next episode in this presentation set.